This table may be familiar news to some of you guys, but I always find it helpful to break down what's going on in a particular shock state because it helps me then guide my therapy for what I'm going to do, both to temporize the patient, to get them through what's going on, and then to hopefully eventually fix them. So on the left here in this column, I have the 4 major types of shock. And then over the top, that top row, are those 4 hemodynamic parameters, being systemic vascular resistance, cardiac output, which of course you remember cardiac output is a function of heart rate and stroke volume, which is a surrogate for contractility. Central venous pressure, and then I put in pulmonary capillary wedge pressure as sort of a surrogate for left ventricular filling pressure, or left ventricular end diastolic pressure if you want to get technical. Sometimes I do. Looking at distributive shock, the most common type of distributive shock you're going to see far and away is septic shock, okay? But it's important to note that a lot of neurogenic shock will also show up here. In distributive shock, the main problem is with the systemic vascular resistance, okay? Something is going on, whether it's a complete loss of adrenergic tone from a neurogenic shock patient or a lipopolysaccharide-induced cytokine storm in a septic shock patient that's causing the capillaries at their farthest level to just open up and completely lower the vascular resistance within the circulatory circuit, okay? So this is the major issue. When that happens, a bunch of downstream things will also happen. The body tries to increase perfusion to the tissues, and the only way it knows how to do that is to try and raise the pressure in the system, okay? The tissues have a certain resistance that oxygen has to diffuse out, and so if there isn't enough pressure in the capillaries, then the oxygen is not going to be delivered. So the body doesn't know how to do that. Obviously, it can't clamp back down in the vessels, or it would, because that's the whole problem in the first place. So what it does is it increases cardiac output. By increasing cardiac output, that's its next best way to increase the amount of oxygen delivery to the tissues. Central venous pressure, as a function of how much volume is actually in the circulatory system, may be decreased just from a nature of decreased resistance within the circulatory system at the capillary level, but it also may be normal. You may have somebody with a completely normal right-sided filling pressure, CVP, and functionally has more than enough gas in the tank, so to speak, but the pipes just have too many holes in them. And so the CVP could be low, or it could be normal. And the same essentially goes for the left ventricular end diastolic pressure. Most of the time, right-sided cardiac output equals left-sided cardiac output, and right-sided filling pressure changes are usually affected in left-sided filling pressure changes, and we'll get to the situations where they're not. So you can have the same kind of function here. A note on wedge pressures. We don't measure these routinely anymore. You're not going to be putting Swan-Ganz catheters or sending your patients to the cath lab to measure their left ventricular end diastolic pressure. We have non-invasive ways of accommodating some of this stuff, but in the clinical situations in which there's a difference between these two, you're almost always going to be figuring that out non-invasively, either with a clinical history and a clinical picture that you're putting together, or more commonly now with ultrasound. Moving on to cardiogenic shock. Cardiogenic shock, the primary problems in the cardiac output. Your most common cases of this are going to be CHF that's fallen off the Starling curve, and acute myocardial infarction. And in some cases, you're going to have decompensated right ventricular failure, which is different than LV failure, being the tipping force in some of this. Again, the primary problem is the cardiac output. You can occasionally have chronotropic reasons that this happens, not just inotropic reasons, which is all of these. Either one of these terms, heart rate or stroke volume, can drop your cardiac output off. So you can imagine somebody who suddenly goes into third-degree AV block and they can't maintain a heart rate. Doesn't matter how good their heart squeeze is, they're not going to have the cardiac output to get things done. So again, primary problem being in the cardiac output. The body then recognizes there's a drop-off in cardiac output, and it does the same thing it always tries to do, maintain perfusion pressure. And so its compensatory mechanism for doing that is to raise the systemic vascular resistance. By raising the systemic vascular resistance, the body may be briefly, transiently improve perfusion pressure to the organs, but unfortunately, you're adding afterload to the circuit. And so often raising this is actually going to worsen the functional overall cardiac output. These are the patients who may have a completely normal blood pressure at 120/60, but not perfuse anything because they simply can't circulate enough blood against that resistance in order to get them better. What happens with the filling pressures? Well, this gets a little into the weeds of what's causing the problem in the first place, but most of the time, you're going to see an increase in filling pressures. Sometimes because the patient physically has too much volume in the circulation, and sometimes because the heart simply can't generate forward flow, so the pressure that it does generate goes backwards into the system. Hypovolemic shock, most commonly manifested in your hemorrhagic shock patients. Okay, so GI bleeders from anything. And very rarely, but sometimes in a pure hypovolemic patient who just didn't eat or drink anything for some time. Their primary problem is the tank itself. The tank is empty. Heart works fine, blood vessels are mostly held together, but they don't have any volume to circulate through it. So the biggest problem that you're going to see here is in these filling pressures. And again, in the absence of other pathology, you should see an appropriate decrease in both of these. What happens to the cardiac output? Well, as this shock state progresses, the cardiac output should hopefully be maintained by an appropriate increase in heart rate and stroke volume. However, eventually, as the tank empties out enough, that cardiac output will go down. So it starts okay, and then it gets worse. And the systemic vascular resistance usually is going to be increased slightly, again, to try and maintain that perfusion pressure. The worse the cardiac output gets, the higher the SVR gets, so initially okay, and then it'll eventually go up. Obstructive shock is a little tricky. Obstructive shock, the biggest problem has nothing to do with the amount of fluid in the tank, but it's the fact that we're not letting that fluid actually get into the heart. Okay? And this could be an obstruction on the right-sided filling of the heart or the left-sided filling of the heart, depending on the pathology. Tension pneumothorax. Tension physiology from the chest cavity filling up with too much air could do it. Pulmonary embolism is a classic obstructive shock where the left side doesn't fill because there's a blockage in the right-sided circulation. Cardiac tamponade can also do this. Most obstructive physiology that's related to the heart as a whole being compressed, whether by intrathoracic pressure or by the pressure within the pericardium, is going to affect, again, in most patients, the right-sided filling first, because the right atrium and the right ventricle have lower pressures to fill than the left side of the heart does. However, in somebody who's had long-standing pulmonary hypertension, for example, their right side may actually fill with higher pressures than the left. So it's important to think about what's going on in your patient from an underlying standpoint when you're trying to figure out what's wrong. Pulmonary embolism is that classic example where the left-sided filling pressures are decreased because the PE's in the way, but the right-sided filling pressures are okay, if not elevated, because the PE has caused that right side to decompensate. So what happens in all of this? Well, it depends on where the blockage is. Most of the time, you're going to see, if I were measuring a CVP, an increase in the CVP, because I'm measuring the CVP up here, problems down here. If I could float a catheter all the way past all the obstruction and get into the heart itself, they might be very, very low. But again, we don't do that in the vast majority of our patients. So I'm going to see that CVP be high, but I'm going to see this LVEDP, this left-sided filling pressure, be low. Remember, the right-sided cardiac output has to equal the left-sided cardiac output. So even though my pressure in my pericardial sac may not be high enough to block my left ventricle from filling, if it's high enough to block my right ventricle from filling, then there's no blood getting through my pulmonary circulation to my left ventricle. So all of these will eventually manifest with a decrease in left ventricular filling and a decrease in right ventricular filling, even though that central venous pressure is going to be high. What happens to your cardiac output? Well, if you don't have any blood to fill your heart, it's not going to put anything out, so it's going to go down. And then you'll see that increase in SVR, but you may see an actual decrease in blood pressure once the cardiac output drops off far enough. So that's hemodynamically what's going on with all of these shock states. is you can think about it, anything with 3 arrows is probably something we ought to target with a therapeutic intervention to either fix the underlying problem or to keep the patient alive long enough to let us fix the underlying problem. So in septic shock or neurogenic shock, I want to give something that's going to increase the systemic vascular resistance. If I have a patient in cardiogenic shock, I might actually be giving afterload reducing agents long enough to get something on board that's going to fix either the heart rate or stroke volume of my patient to keep their heart going, while I maybe try and work on fixing the underlying problem, whether it's an MI or decompensated heart failure. I may diurese these patients as well if I can get them back on their Starling curve. These hypovolemic patients, you can imagine I'm just trying to fill this tank up. But if I need to keep their blood pressure up in the meantime, usually I'm reaching for an SVR active agent because there's nothing wrong with their heart as long as it's got volume to fill. And in these obstructive shock patients, which can be really tricky to work with, I might be doing all sorts of things. They might be getting inotropic agents for their heart. They might be getting vasoactive agents, whether it's afterload reducing or afterload increasing, depending on what's going on with them. And I'm doing something to try and alleviate this obstruction so I can try and get the heart to fill. Most of the time that's bolus fluids while I'm pushing TPA, or I'm draining the pericardial effusion, or I'm putting a chest tube in them. And in any of these situations, you're obviously going to be doing this in conjunction with your attending. And just because I'm stepwise laying some of this stuff out doesn't mean you're not going to be doing multiple things at once. So let's move on now and talk about some of these vasoactive and cardiac active agents that we might be using to help us temporize and fix these patients.